So welcome to the As Live surgery. I'll just spend a minute or two talking about what this session is and introducing the panel, and then we'll start with the videos. So we've got just under an hour. We started slightly late after the last session to cover three aspects of PCNL: supine PCNL, mini PCNL, and ultra mini. And we've got a video which will be presented without any voiceover, and each of our panelists will come and talk about their video much as they would if they were in surgery at the time of live surgery. We encourage you to ask questions as you go along, but much as with live surgery, if there's a particularly interesting part of the video and the presenter thinks they don't want to speak over that aspect and they want to tell you something, they may delay answering your question until there's a natural gap in the video. We'll also hopefully just have a little bit of time at the end for any questions. You can either come to the microphones, or if you want to submit questions through the app, then I'll try and monitor those and feed those in as necessary. I'd like to say a big thank you to all the presenters. Any of you who've tried to put a video together know just how difficult it is. Invariably, in my hand, someone forgets to turn the video on. I find out at the end of a session where I've tried to video something. You'll see that the quality is excellent, and without further ado, we'll start. We're actually going to go in a slightly different order to the one here. So I'll introduce Sharon Scriven, who's from Nottingham City, and she's going to talk about mini PCNL.
Good morning. Thank you very much for inviting me to speak about this technique. As most of you will know, my technology knowledge is minimal, so if this works, it will be a miracle. Okay, so I'm going to show you a case of little Ollie W, no relationship to our next speaker, but he's a 3-year-old lad, currently in foster care, who presented in October with recurrent UTIs and abdominal pain secondary to E. coli. He had a whole gamut of investigations under the paediatric urologist. His usinets were normal, serum urate and calcium were normal for a lad of his age. No evidence of hyperoxaluria, no evidence of cystinuria, but an ultrasound scan did show that he had a 1.4 centimetre stone in his right renal pelvis. And if we hang on nicely, you'll see a lovely representation of this. It's coming. It will come. Here we go. We see a beautiful arc crescent of stone with an echogenic focus beyond it, very typical of a stone seen in kids. And his KUB confirms that he had a radio-opaque stone in the right renal pelvis. A subsequent DMSA scan showed that he got reduced function on that side, about 31%, but sufficient function for us to consider sorting out his stone and not removing his kidney. So based on this, and conjunction with the paediatric urologist and nephrologist, we elected to perform a mini PCNL. And I just show you a little bit about the kit. Unlike conventional PCNLs, two things to be aware of. Firstly, that the scope is a lot longer than the sheath. And secondly, that the scope and the sheath are completely independent, so there's no locking mechanism between the two, so you've got no closed system. It's a nice open system where you've got continuous irrigation from the scope round the scope back up the sheath. The kit comes with a one-stop dilator, but my radiologists prefer to use the Alkans, and so all you have to use is the olive tip dilator, followed by 3 of the Alkan dilators, and then the 16.5 French sheath is the outer dilator. Otherwise, the kit is fairly standard irrigation, light lead. I do use a little sister guard, which is a nice little device to just help you get a little bit of extra pressure, a little bit of extra fluid during the procedure. And when we run the rest of the video, you'll see how this helps a bit. And nice, neat little kit, very ergonomic. So this little lad underwent a cystoscopy, and initially I put in a ureteric access catheter right the way up to the renal pelvis, with access so that you can manipulate it during the procedure and bring it up or down if you need to. The radiologist, John Lloyd, my excellent radiologist, gets me access, puts 2 wires in, a safety wire and a working wire. And then over the working wire goes a disposable 9 French dilator, the olive tip dilator, and then subsequently an 11, 13, 14, and then the 16.5 French outer sheath. Now this looked nice and small when I first showed it. When you look at it inside a paediatric kidney, it still looks absolutely enormous. Once I'm happy that everything's in place, I put the scope over the wire. When I'm certain that I'm in the system, be it in the pelvis or the calyx, then withdraw the working wire. So I've still got a safety wire on the outside of the sheath, but that allows for better manipulation once you get into the kidney. And this is where all the fun starts. You can see the shell of it's quite soft. Because the instrument's so small, I tend to use a laser. There is an ultrasound probe and a lithoclast, but these are quite difficult and quite heavy, I think, with a small scope. So I just use an ordinary holmium laser, 365 fibre, start a fairly low frequency, 5 hertz, 0.5 joules, and then work your way up when you ascertain how hard or soft this stone is. And then just with a little bit of patience, sit there and work away at it, make it into nice dust particles. And as you can see, all this dust is just being washed out continually throughout the procedure. I'm going to shut up for a bit so you can watch this and just get an idea of the technique. When there are some big fragments like this, you just remove the scope from the sheath and all the fragments just fall, wash on up and then fall on out. You have to be a little bit careful, a little bit slow. If you do it too fast, you'll drop them. But after a while, you get the hang of the technique.
Questions for you?
Okay.
Sharon, can I ask you a question? If they don't wash out, do you have a grabber that you can put down?
There is a grabber, but to be honest, I prefer to use a little basket. It's a bit easier because you can often get into slightly more inaccessible places. But there is a basket. But obviously, with the grabbers, there's a minimum amount that you have to be able to get in to be able to open. But to be honest, if you just sit there with the laser, you can just break it up. To get a nice lot of dust particles rather than big chunks, I think the trick is to raise the frequency and keep the energy low. So typically I do something like 15 hertz, 0.5 or 1 joule. If you particularly want to have big chunks, then reverse that and 1 or 2 joules and decrease the frequency. You can use either a 365 fibre or a 500. If I'm doing an adult and I've got a big stone, I will often use the 500 because it's a bit more robust. But you've got to remember that with the fibres, it's actually the power density that's important rather than power. So the bigger fibre you've got, the more energy you've got to put through it to get a good power density. I think in order to get the best of the Venturi effect and the flushing out of the bigger fibres, it's quite important to get your sheath close to the stone and also the sheath and the stone close to the posterior wall, whether it's of the calyx or whether it's of the renal pelvis that you're working in. And that you have a slightly smaller enclosed space and you get a better Venturi effect and it washes out better. Occasionally, if they get a little bit stuck, you can get your assistant to put a bit of fluid through the access catheter that's in place, or you can use that little sister guard just to give a little squish and help the bits come up.
while this stone's being lasered, can I encourage anyone to come up and ask any questions? Certainly in the live surgery, there's never a shortage of people asking questions from the audience.
There's two formats.
Microphone one.
How high on the laser settings would you be prepared to go? Because we're all getting increasingly confident using higher energy settings, and with a 365 fibre as a 550 you've said. So how high would you go? And my second question is, what sort of stone clearance rate per hour would you anticipate being able to do through this? Because with our sort of old-fashioned laser settings that we'd use, we used to sort of quote a centimetre an hour. And what do you think is achievable using your laser settings and this technique?
Right. Well, certainly as far the highest I've used is 50 hertz, 0.2 joules. And with that, it fragments really fast. You do get a big cloud storm there, so you have to be prepared to wait and wash out a little bit. As far as clearance per hour, I mean, I don't restrict it just to small stones anymore. I do this complete staghorns, and for complete staghorn, you can get cleared in 4 or 5 hours if you needed to. The advantage, I think, of this is that you can get into places where you couldn't get into with a conventional 26, 28 scope. The vision tends to be clearer throughout because there is less bleeding. And the nice thing is that you can advance the scope, leave the sheath in, say, in the renal pelvis, and then I'll show you in a minute, but you can advance the scope up into the upper pole, down into the lower pole, places where you would never get to with your conventional scope.
Oh, sorry, microphone 4.
Hi, good morning, Kay. Sharon, I agree with you. When I do paediatric stones, I do the track myself, and I go in and often have a look in first with a 16 French scope. But if I'm doing a big stag in a child where the kidney is large enough, what I tend to do is once I'm less tachycardic than the child, then and there's no bleeding, then I'll increase this sheath to a 26 French sheath and use the conventional ultrasound, and I find I can clear stone quicker doing that. Do you ever do that?
Well, that's the nice thing. I've done that in some of the adults because it's not one or the other. You can have a little look round with this, ascertain how fast it's going to go, and if you want to convert, then just put your dilators back in and increase the dilatation. I haven't in the children gone on to use the bigger size one. In adults, where you've got matrixy stone or something that needs sucking out rather than anything else, you can't suck very well through this because the calibre is too small. But if you've got horrible gooey matrixy stone and you want to put a big sheath in, it's no big deal just to swap over and dilate up.
Great. Microphone 1.
If that stone was not radio opaque, would you have done any other imaging, or would you rely on the ultrasound alone before treatment?
Well, he certainly would. He would have had a retrograde at the time of surgery. We try to avoid doing CTs in the kids, and for most of them, because they're small,
a limited IVU.
We could have done, but our radiologists were quite confident that what was in the kidney on ultrasound was a stone.
Let's have more idea of the anatomy, maybe, before you do a PCNL on a child.
We do a retrograde before we roll them over, so you get the anatomy then.
Already. Might be in difficult access, difficult position, and a diverticulum maybe.
Yes.
So we'd have done no CT or not even a limited IVU beforehand.
He probably would have had a CT if it wasn't radio opaque, but as it was, I didn't.
Thank you. I'm very excited. We've had our first question through on the app. It's 2 actually. What is the role of lithotripsy in this case?
In children, under the age of 12, I've stopped doing lithotripsy, basically because they need a general anaesthetic, and they often need more than one session. And if you're going to give them a general anaesthetic, you might as well offer them a procedure that's going to have the highest clearance in one go. Certainly those under 12 don't tolerate lithotripsy without a GA. Those over 12 don't tolerate it very well either, to be honest with you, and you often end up doing several sessions because they can't lie still or they just don't get on very well with it. So, I mean, there's some centres that do and offer very good results.
Thank you. I think Jonathan Glass is taking up residency on microphone 4, so we'll go back to him.
There's just a couple of other points with reference to imaging. I think you've got to be clear that ultrasound in these kids is fantastic because you often don't need other imaging because the kidneys are only 1.5 centimetres away from the skin. So the paediatric radiologists give you fantastic anatomical detail with ultrasound, which I think is better than we generally get with kids.
Definitely.
And the other point, Sharon, which you've just made is what is important is it's endourologists treating these stones, working with our paediatric urological colleagues, because I think otherwise the paediatric urologists don't think like stone surgeons.
Definitely not.
And they're overusing lithotripsy. They're not keeping up to date with modern stone management. I completely agree with you. It's vital that endourologists have an input into the care of children with stones.
Thank you. That fits nicely onto the next question, which was what is the role of flexible ureteroscopy in this case? Remember, the child's 3.
The problem I have with endoscopic procedures, in particularly little lads that are young, they have very nice wide caliber ureters, but they have a very small urethra, and it's often difficult to get a scope in there. So older children, yes, definitely a possibility, but in the younger ones, the urethral caliber tends to determine. And then it's a fair-sized stone, you've got to wait for all these bits to pass out. The ureter's not usually a great problem, they pass it down through that, but then they've got to pass all the bits out otherwise. So you can see here, this was his final screening. I did elect to put a stent in him. I don't normally in adults, but because I don't look after the children post-op, they go back to the children's ward in a different hospital. My paediatric urologists prefer to have a stent in place. But at his 3-month ultrasound scan, you can see he's completely stone-free, and he's now returned to be a nice, healthy, happy little boy. Thank you.
Thank you, Sharon. I think you've answered the next question that had come through, because it says, what's the role of laparoscopic pyelolithotomy, better stone clearance? But I think it's difficult to see how you could have got better stone clearance than that. Thank you.